Health Committee meeting to order at 1 o'clock. Counselor Warner, will you do the invocation?
Dear Heavenly Father, we thank you for this day. Lord, we thank you for this time of fellowship. Lord, just ask that you bless the Cherokee Nation, Lord, and fill us with kindness, wisdom, and patience, Lord, and just let us remember that the business we do is your business. In Jesus' name we pray. Amen.
Amen. Shelley, will you do roll?
Yes, ma'am.
Joe.
Frankie Hargis.
Present.
Brian Warner. Bill England.
Here.
Dawson.
Here.
Jack
Oh,
Baker.
yeah, I'm on schedule.
Carla Buzzard.
Here.
Joe Bird.
Honey.
Sean Crittenden.
Honey.
Don Garvin. Wanda Hatfield.
Honey.
Rex Jordan.
Here.
Dick Lay.
Here.
Curtis Snell.
Here.
Denise Taylor. Here. David Thornton.
Honey.
Victoria Vesquez. David Walkenstick. Joe LaPorn.
Need approval of the June 13th, 2016 minutes?
Make a motion to be approved.
Second. All in favor? Aye. That passes. And that moves us on to reports for Claremore Service Unit. Hi.
George sent me in his place
And your
today,
name?
so
Could you give us your name, please?
Kathy Smith. He sent his report in, and our visits are up, and we're still recruiting for some chief service. We've made a tentative offer to a dental chief, which that's been a long time coming, so hopefully that'll all work out and get that wrapped up soon. Other than that, we do have the orthopedic, that contract, it closed, and they're reviewing the bids right now. I don't think there was a whole lot of interest, but at least we had some interest, and I think hopefully that'll wrap up soon too.
That's good
So,
news.
yes, that's very good news for our patients, so. Our dental visits are down. I think that's a lot to do with, we're down dentists, we're down hygienists, so we're getting back up there with that. So. Anything else I can?
Do we have any
help you with?
questions? Counselor Walkenstick?
You're the contract health you guys have. I was approached by a citizen. I guess they've been on waiting list for like a year or whatever. Do you guys have contract health funds?
We do. Our contract health funds are very limited.
Okay.
So.
Is it more just it's life or death type deal?
Yeah. It goes to our transfers out of the, transfers out first, and then any oncology patient, and after that, it's real limited.
Okay.
If at all, so.
All right. Thank you.
Yeah, you're welcome.
Sure.
Counselor Buzzard?
I was wondering about the orthopedic ortho contract. If you get those, hopefully you get some out of Tulsa,
Yes.
but if you get them out of Oklahoma City, I hope they're.
No, I don't want them out of Oklahoma City. I think now, I want to say that the group in Claremore bid on it, so that's even better than Tulsa, really. So, yeah, we're Oklahoma City. That's not going to do us any good. So, yeah,
Okay,
yeah.
all right, thanks. Thanks, ma'am.
You're welcome.
Counselor Vasquez?
Yes, thank you. I have a good comment to pass along. During the lunch break, I had a call from one of my citizens, and he and his wife recently were at Claremore Indian Hospital, and he had called some time ago complaining, and today he called to say, I wanted to tell you I think she said the doctor even smiled at her. They were very happy, and he said, I just wanted to call and report that because
Oh, wonderful.
people always call and complain, and so just wanted to pass that along.
Well, thank you. I appreciate that
I
a
did
lot.
too.
So I feel like things are changing. I've been there for over 20 years, and yeah, we've had some bad times, and it does feel good right now. Things are looking up, and we've got some wonderful doctors in our adult medicine clinic. And just all over. Our clinical director, he's doing a great job recruiting physicians for the whole hospital. So
good to
I
hear.
appreciate that. That makes me proud.
Any other questions? Thank you.
Okay, thank you.
And next, we have the Cherokee Nation Health Services. Dr. Montgomery.
Good afternoon, everyone.
Good afternoon.
I'm Roger Montgomery, Executive Medical Director. Ms. Davis, Dr. Graham, Mr. Hale are visiting the Eastern Band today and visiting their new facility for some ideas on the design of our new joint venture facility. So Mrs. Davis asked me to fill in while they were away. If you hadn't heard, I'm stepping down. My last day will be at the end of this week, and I wanted to introduce my replacement, the interim medical director. His name is Dr. James Stallcup. He's with me today. Dr. Stallcup, would you please stand? I've worked with Dr. Stallcup before I came here to Cherokee Nation, and we've had what I would say a very challenging work relationship. If I ask him to do something that he may not agree with, he's very willing to tell me that. And we but also have a great relationship and have had some good discussions over these past several years, and we've always been able to arrive at conclusions, consensus that I think we're all always very willing to work forward on. I have utmost trust in him, and I think by bringing him into this position at the end of this week, it will minimize the disruption of my leaving, and I'm very, very confident in his abilities. He's currently functioning as the Chief Medical Information Officer. He's just a brilliant guy, very, very bright. He is a doctor. He also has a very strong clinical background, and I think, again, will fulfill that role very, very well, and I have, again, as I said, very much confidence in him. Madam Chair, I wanted to do something a little different today, too. At the end of this discussion of the routine report, I've invited Dr. David Gann to be here, and he will give you, I think, a very informative report, and I would like the liberty to do that, which is a little bit different from what we usually do. With your
That's fine.
permission.
Let's address questions first.
Then I would refer you to the report. I think my goal today is just to highlight some of the positive things. The summary highlights would include the visits. For the month of May, there were 136 new activated charts at the Cooey Health Center. As a percentage increase in the total visits, it's substantial. The other, Veneta Health Center, I would highlight, opened 203 new or reactivated charts for the month of May. Again, this reflecting the increased number of patients that are trying to gain access to our health system, which is a very positive thing, but an ongoing challenge. Under the Hastings Hospital, you'll see that they received an overall hospital star rating reported in July 2016, and this is reported to CMS, and it received a 4 out of possible 5 stars related to the patient experience. As far as the staff achievements go, I think this may have been mentioned before, but if not, I've mentioned this physician's name multiple times, Dr. Jorge Mira. He was selected by the Acting Assistant Secretary of Health to receive a viral hepatitis testing recognition award, and he traveled to Washington, D.C. to receive this award and represented Cherokee Nation extremely well, and we're very proud of his ongoing work with the Hepatitis C Elimination Project. Under the patient access category, you can see that the left without being seen rate in the emergency department remains low at 3.5%. Other thing I would emphasize is that there were 139 admissions from the emergency department during the month of May, which is a significant increase. A corollary to that was a decrease in the number of patient transfers. Due to the enormous help of a young woman by the name of Michelle Hood, she is working with the ER staff to look at those patients that come to our ER that potentially would be transferred to other facilities, but with her assistance, we're finding good, positive solutions that enable our patients to be treated at Hastings, minimizing the distance that families are going to have to travel to see their loved ones cared for at other hospitals, and again, receive the care that they need here at our own facility. And again, I'd like to single her out for her efforts. Dental services, again, under the direction of Dr. Jones, the visits remain strong. The access to same-day appointments for emergent visits remains very, very strong, and Steve does a great job. Under the diabetes program, I'd like to mention, she's come to this meeting before, and you've heard her name, Teresa Shadowan. She's been with the diabetes program for several years. They had to reapply for the grant that supports that program. And it was under a new set of rules, a new set of requirements, and with Teresa's experience, with her insight, with her knowledge, we were re-awarded a diabetes grant that increased in amount and is $7.5 million a year over a 5-year period for a total of $38 million. This is a crucial award that allows for the services that are unique to our health services in the caring for diabetes patients. And again, I'd like to recognize Teresa for her outstanding efforts and success in being re-awarded that grant. I'd also like to single out the Jack Brown Center, the director, Darren Dry. I don't know if his name has been mentioned before, but he's been there several years. Wonderful fellow, very dedicated, and very understanding of the needs of young Native youth that have emotional and substance abuse problems. They were recently evaluated by the Oklahoma Department of Mental Health and Substance Abuse and received a certificate with special distinction. Very, very noteworthy accomplishment for Director Darren Dry and our Jack Brown treatment program. Then I would also like to single out our Behavioral Health Services Department in the direction of Mark Taylor and the Administrative Director Joni Duffield. I'd also like to single out the HERO project directed by Julie Skinner. You can see the number of visits that were provided, 1,921. What I don't have here, and would be happy to provide you though, is a graph that represents the steady increase in the number of visits occurring in our behavioral health department, which in my opinion reflects increased access. It's just not a matter of hiring more providers. We have developed scorecards for our behavioral health providers so that we're tracking the number of patients they see, the number of patients they schedule, their number of no-shows, and this has led to a steady increase in the number of patients that are receiving behavioral health services, and I'm very, very proud of that. Then I'd flip you on to the ambulatory care visits by facility. You can see there's some ups and downs, but overall most of the clinics are seeing an uptick in the number of total visits. And then the total ambulatory visits for the month of May, comparing from the previous years, thus far 95,852 visits for fiscal year 2016. I want to move on then to our recruitment summary. This is further back in your packet. Recruitment and retention of our providers is essential to the lifeblood of our system and our access for patients to health care. And in my 4 years here, I've seen this ebb and flow. Or when I first came on board, Jay was struggling to have providers, and the word was, you'll never get new providers in Jay. But we gradually hired more providers, and in that time, we've seen the number of providers in Sallisaw drop dramatically and have struggled over the last 8-9 months to get providers. And here's the interesting story. In the last 6 months, we've had 3 providers hired by Sallisaw, and they all came from the same neighboring facility. It all started with a pediatric APRN, Heather Lloyd. She heard about Cherokee Nation. Someone said positive thing about Cherokee Nation Health Services. She said, you know, that may not be a bad place to work. Came to work and called her friends that were working with her at her old facility and said, you know, this is a really great place. I really like you. I like working with you. Why don't you come to Cherokee Nation? Well, that was followed by Tracy Files, a physician assistant. He left that old facility, came to work at Sallisaw, and then that was followed by a doctor, Dr. Marcella Jones. She left that same other facility and came to Sallisaw. So in the last 3 months, we've signed on 3 new providers at Sallisaw, where I thought we might not. I just was really, really worried about the success we would have at hiring providers, and we've done a great job. The other facility to single out, in the direction of Dr. James Baker and the administrator, Charles, and I want to also shout out to Jerry Kaufman and Dr. Skylar Steelberg, the directors there in Sallisaw. The other facility I'd like to give some recognition to is to Dr. James Baker at the Three Rivers Health Center and Mr. Charles Smith. In 1 more month, they will be completely flush. They will have no vacancies. They've hired 3 APRNs in the last 2 to 3 months, and they've got 2 new physician providers coming on, one I think next week, and another will follow that a couple of weeks later. Three Rivers will be flush for the first time in a long time. So again, there's ebb and flow. We still have some vacancies left in some of the other clinics, but we have, under the direction of Stephanie Wycliffe, the Director of Recruitment and Retention, and her staff. Formerly, Ben King was with our staff, Jennifer Leap, Diana Turtle. They've done a wonderful job with recruitment, and I want to give a shout out to all the directors who've done a wonderful job with recruitment providers for the clinics also. So again, those are some of the highlights. I'm happy to take any questions from the committee.
Okay, I have Counselor Taylor first.
At Intertribal, I attended a meeting that was dealing with healthcare, and they had a representative from Walgreens there who stated that, okay, it sounds like you're familiar with the program of providing to Native American clinics at a discount prescription drugs that we do not carry in our pharmacies. Is that?
I was nodding my head because I thought you were going to ask me about something else. I'm sorry, I should have waited. No, I'm not familiar with that.
Okay, so if we could just, and Jeff is back there too, so if you guys could just obviously you have a relationship with Walgreens, if you could just reach out to them and inquire about that.
Jeff,
It
do you
sounds
have
like it's
anything
a
more?
win-win.
I really don't have anything to add. I did have one discussion with, I believe it was just a manager, it's been a while back. We've had all of Tucson actually, so.
Let me see if this gives a name of who presented, and I'm not sure that it does. Jim Wood is who presented on behalf of Walgreens and discussed that program.
Will do.
That's all I have.
Counselor Crittenton?
Appreciate your service to us, Dr. Montgomery. It's been nice visiting with you over the year I've been on.
Been my pleasure, too.
Appreciate you. Kind of handy having you right here. Just got a text. I've been keeping up with this person. Really sick man. His family's from Stillwell area. He did a lot of the computer technical things for the Cherokee Nation, but he's sick, and his family's wondering, do we have any type of transport service? He has to meet with a doctor in Oklahoma City, and I'm surprised I don't get more of these questions, but I just don't know. Is there any kind? He said not an ambulance, something with lifts or something, because this lady and her son don't know if they can lift him in and out. Anything?
My response would be that I know we've encountered a similar situation in Jay once before, and I don't recall the exact specifics of how we reconciled that. But there is obviously the routine transportation that's afforded to patients to and from within a certain distance, but this, you're saying, would be to Oklahoma City? Then in that regard, I would say let me get that additional information from you and get back with you either later today or first thing tomorrow.
Thank you. And you have my email, don't you?
You bet.
And
You
I
bet.
appreciate anything
You bet.
that you may find, or if any of the council has ideas that another department may be able to help that I don't know, please let me know. And
Will do.
it concerned me, and I believe everybody done what they could do. We had a situation come up and visited with Brett and different ones. Had a sick gentleman referred to Hillcrest. And when I think of Hillcrest, I think of heart doctors, maybe because that's where my grandmother had her bypasses and different things.
Right.
But so we referred him there. A doctor, recommended that this guy take home a piece of medical equipment, and there was no way that we could pay for that. And it was brought up that maybe he didn't need it, but my thoughts were, a doctor we refer them to, that we refer them to.
Mm-hmm.
If we have faith enough to send them there, his recommendations, we ought to have faith in those too.
Right.
And find a way. And so that just concerned me a little bit. And Brett and different ones been helpful as they can be, but regardless of that, I didn't understand that at all.
I've been a doctor a long time, and all I can say is that, again, when I refer someone to a specialist, you're right. I typically refer them to that doctor because I trust their judgment. I've had experience with them. They've done the right thing for me in the care of the patients that we mutually are caring for in the past. But on occasion, a patient will be prescribed a medicine, a test will be ordered, or they may be prescribed a certain treatment that I might not agree with. And so what typically happens in that situation is a discussion between the two doctors about why we don't agree, and we try to come to some reconciliation. But it does happen. Doctors don't always agree. But I do respect your concern about the nature of a patient being somewhere else, being recommended a certain treatment, and then Cherokee Nation not affording them that treatment. And all I can do is say, give me the specifics, we'll look at it very carefully and try to give you as best a response as I can.
Thank you, sir. Thank you.
Counselor Walkenstick?
Dr. Montgomery, I guess words are inadequate to express our gratefulness and appreciation and your positive attitude of what you do for the tribe. And you've been a vital role player in our health community. And it's hard to recruit good people like yourself. And I wish we had fully staffed Dr. Montgomerys out there, but you're going to be missed. And I appreciate you coming and serving for our tribe.
Thank you very much. It's been an honor.
Yeah,
It's been an honor.
thank you.
Counselor Garvin?
I concur with what Councilman Walkenstick said. I watched Roger over the last 4 years. He's done an outstanding job for Cherokee Nation. And I sure hate to see you go, but I know somebody else is getting a good job. But we appreciate all your work and your efforts. You've been outstanding, and I'll give you an A+ as a former teacher.
It means a lot to me. I appreciate that very much.
Thank you.
Counselor Warner?
Yeah, thank you. Doc, I feel the same way. You've been a big help. Everything that I've ever called you about, you helped me out. One thing that we talked about, it's been about a month and a half ago, we talked about the pain management
Yes.
and testing. Are we anywhere on that? I mean, are we still kind of standing our ground as far as, or can you explain to some of those that may not? I think most everybody probably has seen some stuff recently, but you know, the way I understand it, we are taking up the testing, but the pain management clinics aren't accepting our testing.
Correct. Correct.
Where are we at? Are we anywhere in with this?
Yes, and I've got to be very careful in the selection of my words. I hope
Yes,
you
sir.
understand that, not with reference to you, but just because this is a very, very tough issue. There was an article this morning that, I think it was OK Oklahoma, it's an article from the Oklahoma newspaper, that showed the difference in the cost charged for a urine drug screen at various places across the country. The highest was $2,500 for a urine drug screen. The lowest was $200. What's up with that?
Right.
How could something be that different in one place, that low, and that high in another? And the answer is very simple. And the doctors that I think are very forthright about this will tell you they need the money from those drug screens to support their practices. We're not paying for the actual cost of that test. We're paying a fee that helps support the overall operation of those clinics that see the chronic pain specialists. All right? So we were getting charged an amount that we thought, well, we knew was over time going to continue to eat away at our contract health costs. And we said, we can't continue to let this cost grow. We need to have some discussion about what to pay for this test that is used, performed frequently, and would amount to a significant burden on our contract health system. And so we approached some of the different clinics, and they were willing to negotiate with us. Some didn't necessarily want to negotiate. They just said, sorry, no more. And that's put some of our patients in limbo. I'll be very, very willing to admit that. But again, I want you to know from the standpoint of Cherokee Nation, we did not draw any lines in the sand necessarily. We just had to make clear that we need to negotiate with these people on what we were able to responsibly pay for a test that's utilized quite frequently in the care and management of chronic pain patients. And so, yes, we've reached decisions with various groups. We have a variety of groups that are willing to see our patients, but we do have some groups that are not going to. And we're working as quickly as we can to address that, give our providers time to identify those patients that will need to be referred to other doctors. But there will probably be a few calls to you about these patients that are not being able to be seen by their current provider or their current pain specialist. But our providers are knowledgeable of this and will know who to refer those patients to. Is that an answer that makes sense?
Well,
That's good.
You know, patient A that calls me, the company is telling him that their test provides so much more of an analysis. Is that correct or is that incorrect?
And that gets into some of the detail of it. Yes, there's a standard. The initial screen is a what they call a qualitative screen. It just identifies the different medications or drugs that are in the urine and not the level.
Right.
And there can be some, it's not as accurate as that next level test.
Right.
And that's the one that costs substantially more.
Right.
That's called the reference test. And so, yes, we're working with them, but we've reached an agreement on what we're willing to pay for those reference tests. And it will mean that they will be done in those doctors' offices, not necessarily through our lab.
Right.
Some of the doctors are willing to accept our results, the results that we do in our lab, but some others will want to do that test in their office for the reason I said.
Right, okay. All right. Thank you.
Counselor Buzzard.
And you've answered some of my questions, Dr. Montgomery, and thank you for assisting me at the J Clinic on several occasions. I've had those times. Just have 2 or 3 questions
Yes, sir.
and comments. One is our behavioral health services in J. We don't have that person up there, and I've got a couple of calls. Are we looking actively to fill that position up there?
We are, and we hope that we come with, again, Mark Taylor, the Director of Behavioral Health, is working on a temporary solution, trying to get providers from one of the other clinics, a couple of the other clinics to come up there a couple of days a week until we're able to identify a permanent position, provider.
And then the other one is the patient services advocate at J. Just the rumor mill that we weren't going to replace that. We were going to get somebody to do the same work, but it wasn't called a patient services advocate. We really need one up there. I've had some people call me. Matter of fact, I taught my wife it was. But I've had a lot of people call at the house just because they can't get through the system yet. So
Right.
that system is really important. I think not only for J, but every clinic that we have. So
Right.
you would check on that.
I will.
The other question I had is, you said there were 99 patients that were held back and didn't get referred out in your report.
This will be the contract health
You
report.
said you had a lady in there that was looking them over and they weren't referred out to the hospitals or clinics. And I was wondering what some of those were, some of the 99 people that didn't go out. Were they for casting or for other medications that we're doing in-house in Hastings now?
I'm going to ask for Mr. Hayes' help on that one, because he may know more of the specifics, and if he doesn't, we will look into it.
Not specifics, but I assume it's
I'm
going to
just
be.
wondering kind of what some of the diagnoses were that we weren't sending out.
A lot of times we'll have, maybe they've had some chest pain, but they don't have an active MI going on. And that can be maintained and managed locally. Is that accurate? Stop me if I.
Go ahead.
So that's an example, ortho that can be it up followed up on the next day or something like that. There's
And
a
you
number
talked
of
about some
things.
shots and stuff like that for ortho.
Mhm.
Okay.
It's just Dr. Michelle would be a better resource, but there's all kinds of things that we've kind of routed things through where they can, take advantage of what we can do.
And I agree. I think we need to do in-house as much as we can. It's not a problem. The other thing is, talked about the vacancy up there and the patient services advocate. The other thing, and I'm still on my garden stuff, I know there's a department within the health department, the Healthy Nations. They deal with that, and you may not be too familiar with the Dr. Montgomery, but they go around and help organizations do gardening. What I'd like to see is a gardening at our, I call it a retirement apartment, but those 2-story apartments where we have elders that live in there. Because I've had some requests that they'd like to have garden, but they can't stoop over, and if we could get those raised gardens.
Raised gardens. Uh-huh.
And I know the person in charge of it, and I'll call them
Very good.
and see if they can help. The other thing, and this is just kind of an FYI, if you'd pass the message on, I had an elder person who was at the J Clinic, and a lot of those pictures up there are pictures of family members. Used to live in the area, and some of them have gone and passed on, but they have pictures of old family members in there. And this one lady was back there looking at pictures, and I took it. She told me she was kind of rudely told to get out. I said, well, let me talk to the director, because we shouldn't treat our patients. She was an elder, and she just wanted to look at pictures, and said, I was the only one in the hallway, and said, this lady comes up, she said, well, our open house is over. I said, you're not allowed back here. I was thinking, that's no way to treat people, no way to treat elders or anybody. I wish we could tell the people who work there that those employees go there, they're the ones, that's the reason they have a job there.
Right.
And they could have handled it a little bit different. Yeah, they could have said, well, come on, I'll take you on a tour. But there's only like one a week or 2 a week or 3 a week or something like that. But sometimes they think they just forget and say things like that. But as council members, we get those calls. And they need to be a little bit more patient with some of our elder patients to go in there, because she didn't know that she wasn't supposed to be back there. And I realize, there's HIPAA violations and HIPAA going on, but, there's different ways for those people to handle it. So I wanted to bring it up for the director, so Connie's not here, but I'm passing it on to you, so
And I will
they
pass that
need,
on.
they need to have a little bit more patience and be a little more accommodating to our elders and to our patients in general. But anyway, Dr. Montgomery, I appreciate the work that you've done here for the Cherokee Nation. And wherever you go, I'm sure they'll benefit from your services there.
Thank you very
Thank
much.
you.
Thank you very much.
Thank you.
Counselor England?
Yeah, thank you, Madam Chair. And Dr. Montgomery, I just want to echo what Councilor Walkenstick and Harlan just said. You're going to really be missed here because you really kind of kept our health department, and you're always out where we can reach you and you guide us and help us and everything. But I also want to welcome Dr. Stallcup. He's my old physician, and I think he'll step right up
think he will,
and
too.
back you up real well. So
Thank you for saying
I
that.
think that's a good choice back there.
Thank you. Great.
Thank you.
Great.
Any other questions? Counselor Lay?
Well, I've got both of you inside. Let me ask you the trip to Jane Phillips. I just wonder how that's working out.
I think we'll, I think, I don't know if we have something signed back, but we, you know, yeah, it's gonna work out well.
And I'm sure Dr. Stallcup has been notified that effort needs to be probably ongoing.
I haven't notified him, you may have.
I haven't, but I will as of
He
today.
is now.
Trust me, if you guys forget, I'll remind you.
I'm sure.
Thank you.
I just had a comment.
Okay.
Dr. Montgomery, we really appreciate what you have brought to the Cherokee Nation. You've really enhanced our staff, and the strategic wisdom that you bring, I think, is a big part of why we have our providers filled in most of these clinics. You know, the historic joint venture we signed, you know, you were all a part of that. It seemed like it was just last year that you came on board, but it's been 4 years ago. So,
It has been.
you know, you've earned your time, and I'm happy for you that you're going back and spend some time with your family. But if there's ever a time you want to come back, it's a revolving door.
Well, thank
We
you.
appreciate everything you've done. Well done.
Thank you.
Okay, we'll move on to old business, which has none pending, new business, none pending, so we will move into your presentation.
I counted 16 council members, I think, today.
Yes.
If I was to ask all of you, how many of you, and you don't have to raise your hand, I'm not asking you to answer, but if I asked how many of you had high blood pressure, or asked how many of you had diabetes, that would be a survey. And the other thing that I might ask is, well, what are your ages? And just looking at you, some of you are about 15 and some of you are about
There you go.
65. But really good. No, then that would be a survey of a group of Cherokee citizens, and there would be a percentage of you that had high blood pressure or a percentage of you that had diabetes. And then as medical director, I could say also, what other kinds of problems do you have? And that would then say to me, percentage of diagnosis, the diagnosis that most of you had, might be where we want to focus our health services, our health service dollars. And I would want to bring that information back to you as council members and say, support our health services to try to address these problems because they're important to Cherokee citizens. They're important to the overall health and the future of our tribal citizens. That's what that survey would represent. Well, today we're very honored to have a person that's going to speak to you, Dr. David Gann. He's going to tell you about the scientific questioning and analysis of tribal people and look at their causes of death, because knowing what our tribal citizens die from should inform us and help us to better understand where we should focus our efforts. And again, he has what's called a mortality report. And very briefly, Dr. Gann, what are why him? Why do we want to trust him? Well, he's a 1988 graduate of the U.S. Coast Guard Academy. He served 6 years for the Coast Guard as a line officer, and then he joined the United States Public Health Service and attended medical school at the Uniformed Services University from 1994 to 1998. He completed his residency in obstetrics and gynecology in 2002 at the University of Texas Medical Branch in Galveston, and he received his Master's of Public Health from Emory University in 2012. He's currently a physician at Cherokee Nation's Hospital in Tahlequah and is also the medical director for Cherokee Nation Public Health. Dr. Gann has done the training and has the understanding to look at populations of people and use science, the science of epidemiology, to better understand the causes of illness, the causes of disease, and the impact of those illnesses and disease on that population, And then that enables people like me to then talk to you about what's important to our tribal citizens and their long-range health. Again, thank you, Madam Chair, for allowing Dr. Gann to give this presentation.
Good afternoon.
Good afternoon.
Dr. Montgomery holds me in too high of regard. I'm just a doctor. But what I hope you've all received this last week or with the packet today, the cause of mortality. The numbers in here are publicly available numbers from death certificates from the Oklahoma State Department of Health. The first few pages of the report are really a primer on public health. We have the Public Health Department led by Senior Director Lisa Pivick, and it's also called Healthy Nation. Sometimes you think of wings and the community gardens and the school gardens. We do a whole lot there. I work for Lisa as Medical Director for Public Health, in addition to my duties at the hospital. And our approach to medicine and disease is very different from a physician's or a hospital's approach to what we need to do. So in our hospital and our clinics, once someone walks through the door, we take care of them. And public health goes out to the communities and tries to change the environment in which these people live. When I see a woman in the clinic for her prenatal visit, and she's not taking her vitamins, and she's not eating well, and I tell her, do you need to take your vitamins and eat well? And she goes back to the environment where she wasn't doing that, little's going to change. So we work out in the communities, and so this, like I said, those first few pages are just about public health and our approach. And what's most remarkable is that if you look at the cost effectiveness of how we help people stay healthy or get healthy, one of the least cost-effective ways we have is clinical interventions. To send someone to go see the doctor to get better. It costs a lot of money and doesn't have a big impact in our communities. If you look at the risk factors for diseases that cause people to die early, and it's universal, is socioeconomic status, which is education and income. And as we look at the data in Native Americans in Cherokee Nation, I can't just pull out Cherokees from these data. It's Native Americans within the 14 counties. The primary causes of early death are cigarette smoking, poor nutrition, and lack of physical activity. We know that. It's the same for any race throughout our country. What's difficult for us to quantify is the behavioral health problems that our patients have out there. Very difficult to treat. There's a lot of social stigma, and we don't have a lot of data for me to tell Dr. Montgomery, this is the area we need to focus. This is where we need the most people and resources. It's just like anything, it's limited. If you go to the page with the chart, CDC pulls out a chart like this for the United States every year for causes of death in different age groups. I created one for Cherokee Nation. Now, the one that comes from CDC just has 1 year's worth of data. Because our numbers are relatively small, I have 10 years of data. And I'll just point out a few things in these graphs that follow. And these are the things that keep me up at night wondering how can we help these people. If you look at the age group 45 to 54, those are young people in their prime that are at the peak of their skills and their jobs. The number one cause of death there is heart disease. It's very different from the general population. In those 10 years, 2005 to 2014, 286 Native Americans in Cherokee Nation died from heart disease. That's young. Now, all these data that we get from the State Health Department, we know that there's an issue called born native die white, that a lot of people's races are misclassified when they pass. And we've been able to fix some of those data with help from CDC and the National Cancer Institute and the Oklahoma State Department of Health through 2009. But we haven't been able to fix the data beyond then. And CDC announced a few weeks ago that they found the funds and the technical assistance to get that done. So these numbers that you're looking at are low, and about at least 30%. So add 30% to these numbers, and that's the number of people who pass from these different diseases. The chart labeled number of deaths among Native Americans, those are just numbers, those are not rates. And it's quite obvious when you look at the number of people who died, and this is just 3 years worth of data, 2012, 13, and 14. Heart disease and stroke are the #1 killer of our patients. And I use the terms interchangeably, our patients, our people, our population. They mean the same thing. Not everyone who's Native American in the 14 counties utilizes our health services. So I can't query our database and give you a picture of what's happening in our communities. I can tell you what's happening in the hospitals and clinics. But these are numbers, again, from the Oklahoma State Department of Health, from death certificates, add 30%. That's what we're looking at. Now, there's old Latin phrase called memento mori. It means basically that you have to die of something, and I hear that a lot. I heard that from my dad as he was passing away from lung cancer, at the age of 70. And there's a number we use called years of potential life loss before the age of 75. And so we can measure, kind of get a measure of how early people are dying from these different diseases. And I can think of it having been here at Cherokee Nation for 14 years, our elders are our culture, right? They're the people that are out there teaching the kids the names of the plants and how to fish, what it means when the wind blows from the east in the morning, and how rabbit lost his tail, and all those things are very important to us. And so if we look at the causes of death with the years of potential life lost, again, this is 3 years worth of data, 2012, 13, and 14. About 7,500 years of potential life loss before the age of 75, just from heart disease and stroke. So that's cigarette smoking, that's lack of physical activity and poor nutrition. So when we worked, and appropriately worked very hard to keep our clinical services going, it's the kid who's 4 years old that grows his first cucumber and learns from his grandmother how to eat that cucumber and what it means, that maybe won't get heart disease 30 years from now. So the public health work that we do is very slow, right? It's not like CPR. It takes a generation for some of our projects, but we're out there doing them. We have 12.5 people with master's degrees and PhDs. We have evidence-based programs, and all of our programs are funded through federal grants and some federal grants that go through the state and the Tobacco Settlement Endowment Trust. But we have some awesome, awesome people that are out in the community doing some wonderful things. So again, for these years of potential life loss, add 30%. You're looking at 10,000 years of potential life lost over 3 years. So 3,000 years of wisdom. And that's just for the age of 75. It's not like when you turn 75, you're not useful anymore, right? But that's kind of the national benchmark we use. So my report's not as cheery as Dr. Montgomery's in what we're doing, but it's real, right? So in motor vehicle accidents, that's alcohol and seatbelts. The reason that number is so high and the number of deaths is so low is because it's young people who are dying from those. So what I'd ask you to do is just contemplate these numbers and what it means for your communities and what it means for Cherokee Nation. And we're poised and we're out there working. It's slow, difficult work. And I think Lisa Pivick has brought Cherokee Nation Public Health at the national forefront. There's no other tribal public health department like ours, even close. And she's the one that CDC calls when they have a question about tribal public health. And the support we've had from Dr. Montgomery and Connie Davis and Chuck Grimm has been fantastic. Every month for the next many months, you'll be receiving reports from me on smoking, on heart disease. We have a lot of data on our kids from the schools. And I just ask you to think about it. There's a lot that our legislative body can do to help get these numbers lower. And whenever you want to talk, please call.
Okay.
Councilor Byrd?
Yes, Dr. Gann,
Yes, sir.
good report.
Thank you.
I see and I hear a lot of comments about our clinics and how many patients each clinic sees monthly. We get those reports. And I oftenly visit our wellness center there here in Cherokee County. We have 10,000 members there. And when I look at and compare the numbers that we have at these clinics, you'll see around 11,000 visits, sometimes 9,000, between 11,000 visits. And I've always advocated, we need to put more funds into preventive types of medicine and healthcare. And, you know, if you're going to do the percentages, you know, we're putting a minimum amount in preventive medicine, and we're putting an enormous amount in, and, you know, and we're reacting. And I think that was good 20 years ago. That's all we had when we had IHS over our old Hastings Hospital, where the optometry clinic is now an issue.
Yes, sir.
Times have changed. I think we need to put more time and emphasis on preventive type of health care.
I agree. We have things we call shelf plans, is when we have these ideas and we sit around and we make up a plan for an intervention, whatever that might be, and there's no money, and we put them on the shelf, and we have a whole shelf full of them. So when opportunities arise, and one of the things Lisa Pivick is very good at is we don't apply for grants just because they're there. We apply for grants that meet our overall strategic plan and needs as documented by the data of the people that we care for. And I think if you ask, what we ask ourselves when we look at these numbers, what is this going to look like in 10 years? What can we do as a public health department to get these numbers to go lower? And we're working as hard as we can with our community coalitions and through our public health educators, which are these tremendous men and women with master's degrees in education and science, kinesiology, communications. We have a woman who's has a doctorate in public health from University of Kentucky, who's a Cherokee woman from Foyle. I didn't know about Foyle till she showed up outside this room, and she's a wonderful woman, brilliant. And when we advertised for her job, we were looking for an epidemiologist. We had 4 Cherokee women with PhDs in epidemiology who applied for the job. So the talent pool is there. It's the infrastructure that's dependent right now on federal grants, and you know how dependable that can be. So we're working to bring some stability to the people that work in the department.
Any other comments? Counselor Buzzard?
Yes, Dr. Gann, I appreciate the report. And I read this at the house, and I was just looking at these figures, and it amazes me about the heart disease and stroke. And those are preventable. I know that probably some of the committee members get gardening and vegetables and stuff like that, but you just grow a profession for years and years. And that's part of it. You know, we got to have good drinking water out there for people. You get those diseases, and the next thing you know, they're right up there to the hospital with the doctors. So I think what the speaker said a while ago about investing, you know, we've got some projects coming up as far as gardening projects going. It takes time. Just what you said a while ago, it takes time to do what you're doing, but, you know, we've got to start someplace.
Yes, sir.
We've got the buffalo in here. We've had them, what, 3 years now, 2 or 3 years? That's a start, you know. We haven't figured out yet what we're going to do, but that's a start. Gardening project, it's a start. You know, it's going to take some time to get our young kids and our young people to doing that stuff again, because they don't do it now. Most of them are playing games, computer games, and they're not doing it. So I'm glad that you come and did the report. I really respect what you said, because I know what you're saying is true.
Thank you.
Thank you for the report.
You're welcome.
Counselor Hatfield?
Is accidental poisoning drug overdose?
Yes, ma'am. So it also includes what you might typically think of accidental poisoning, but a majority of those deaths are drug overdoses with illicit drugs. I can't, from the data that's available to me, pull those apart. Oklahoma is one of just a few states that participate in the National Violent Death Reporting System. It's called the Oklahoma Violent Death Reporting System. And so we have some information on drug overdoses where violence occurs with that. And it's difficult because the numbers aren't too high to put it for our population. But
Well, I'm very surprised that the number is as small as it is, that would be overdoses because of the severe problem we have in Cherokee Nation.
Sure, and the data come from death certificates, and I've had the unfortunate circumstance where I've had to fill out death certificates myself, and some doctors don't put a lot of effort into it. So if I take a lot of drugs and I have a heart attack and die, it's up to the doctor if I died from drugs or if I died from a heart attack. our hepatitis C numbers. You know, we can't figure out exactly how many people are passing from hepatitis C because it's not very well reported. Because if they die from liver cancer caused by hepatitis C, it might be put as viral hepatitis or liver cancer.
I think these statistics are important, you know, maybe to help programs for our youth, to have more for our youth. You know, we complain constantly about kids being on a computer, but at the same time, I mean, we don't have much for them to do. You know, and if they're not involved in sport program, I know that's, I'm getting off track from,
No,
you know.
not at all.
But if we don't have things for kids to do, then they're going to be, they won't be growing, they won't be healthy, and the family structure has changed.
If home isn't a nice place to be, they're not going to go home.
Exactly.
And that
So-
applies to teenage pregnancy,
So-
to drug use, to teen smoking, to poor nutrition, et cetera. Yes, ma'am.
I mean, I know it all intertwines, but that's where we have to start was, I mean, really emphasize our young children, I mean, our young, you know, younger adults, because it is a big problem, not just here, but everywhere.
Yes, ma'am.
Thank you. Thank you.
Okay. Well, we appreciate your report.
Thank you for having me. I appreciate it.
Okay, announcements, the next meeting is tentatively scheduled for Monday, August 15th at 1 o'clock. Any other announcements? Need a motion to adjourn.
So moved.
Second.
All in favor?
Aye.
We have 9 minutes.